So thank you very much for that introduction, and there's been some fascinating talks already. So no gold, no glory. There were several titles that I could have thought about here, and like some of my colleagues before me, there was multiple examples, but I was trying to sort of think around something in terms of some work that we'd done recently. So I'm going to take you on a little adventure, and this is the world of natural language processing, so AI, medicine, and, well, failure. So specifically, we tried to use this AI technique called natural language processing, and I promise this is very high level. I'm not going to go into too much technical or clinical detail, but it's just to give you the sense of what we were trying to do. And we were trying to diagnose sarcopenia, and I will explain a bit more, but that is the age-related loss of skeletal muscle. Our team is from Newcastle, Birmingham, and is made up of clinical input from Professor Miles Witham from Newcastle, who's a geriatrician, along with fellow clinicians and data scientists from Pioneer, the acute care hub, as Kevin mentioned. And this was work that we were doing funded by NIHR on a grant called Admission, which was looking at multiple long-term health conditions. So let's, without further ado, dive in. So I also thought that maybe my slide should be called Mission Implausible, but either way, let's see what the challenge was. So in research, we love structured diagnoses and codes, but not everything in healthcare is that neatly coded. Not all conditions get recorded, and especially when we look at those aging syndromes such as frailty and dementia. And sarcopenia is another one of those sneaky ones. It exists, but often isn't formally diagnosed. So there's no official label in our systems very often, and there's no easy way for us to find those patients in what we call that structured coded data. And that was why we wanted to start this study. So how do we begin? And we thought that that's where this natural language processing came in, and the use of AI to look at those unstructured clinical notes and records. So sarcopenia was where we decided to focus, and not unsurprisingly, with a geriatrician on board. So it is an age-related loss of skeletal muscle, and it's not just about getting weaker. It really is linked to some quite serious healthcare conditions. So it's really important that we do code this and identify it. And you can see some of those conditions here on the screen. So things like falls and disability leads to patients coming into hospital more frequently, and sadly, early death. So you'd think that we'd be tracking it carefully, right, in our codes? Well, no. So often measures of strength aren't often done. The diagnoses are not recorded. And even when they are diagnosed, it's not coded in a structured way. So if it's not in the records, does it even exist? So that was our question, to say, how do we actually use that AI technique to bring that along? So could it help? The plan was to use NLP to find those mentions of sarcopenia in our clinical notes. Just from an information governance perspective, the text at the bottom is made up, so this is not a real patient. We're just using this as an example. So we look for the mentions of sarcopenia in clinical notes, but also have to search for those related words, things like muscle loss, frailty, weakness. And so, as I say, at the bottom of the screen, we have that fake data to try and illustrate just very briefly how that's working. We have those green boxes which indicate that positive association. So, for example, we see muscle weakness and falls. But also, it's really important that we actually pick up the negative mentions. And so things like the patient had a family history of sarcopenia doesn't mean this patient necessarily has. So we can't code that as a diagnosis. So we've extracted the features. We've built an algorithm. We're starting to find things. So success. So you're thinking, why are we talking about this today? Well, not so fast. Not so fast. That's the gold. That's the gold that I talk about. There wasn't a gold standard. So here's where things start to fall apart. So normally we validate an AI model, comparing its predictions to that gold standard, so that actual diagnosis confirmed by a clinician in our records in this instance. But as I say, it's not often recorded, it's not often coded. So all of a sudden we didn't really have that benchmark to check our model against. So we'd found patients who we thought probably had sarcopenia, but we didn't really have that way to find them in our records. So now we have a problem. And actually, we start to have to sort of come together as a team to really sort of think about, well, what is it we can do, and really work with our AI technicians and our clinicians to say, okay, now how do we work around this? We can't do our normal comparison, because sometimes when we're finding things like diabetes, it's very structured, it's very coded, but this isn't. So this was the fun realization now. So, and I sort of love this analogy that it was like building a spell checker, and we got that, but there's actually no dictionary to compare it against. So that's what happened to us. We got a model, team had worked incredibly hard, and actually we got patients we'd identified and a likelihood, a percentage chance that this patient had sarcopenia. But we didn't really know whether it was right or completely wrong, and we had no way of knowing. And this was where we felt like it was detecting ghosts. There's no way to actually confirm it was there, and we needed another plan. So at this point, we sort of looked at different ways. Were the diagnostic codes? There were some, but they were sparse. And so we didn't have enough to really examine that. Things like hand strength and sitting and standing tests. But again, the problem is there if you're only doing it in those patients who you think have sarcopenia. So in terms of the modelling, it did skew and bias our findings, but also it was quite limited. Finally, we then looked and said, well, okay, is the frailty recorded? But as you recall, that's also an aging condition that we don't record that well in our structured format. So we were back to that, oh dear, we've now got something, we don't know whether it works. So we were like, okay, we need some better validation method. And that's really where we were sort of heading. So to really bring this to the close, because obviously the key bit is, well, what did you learn, Suzy, and your team? And I guess the thing is sometimes just because you can find codes and you can find text doesn't mean you can validate it. And after we tried all of those different proxy measures, and we were hoping that we could use other measures as a stand-in for that validation, but honestly, they weren't robust enough. The correlations weren't strong, and without that structured diagnosis, we were very still much in the dark. So this was the point really at which we had to stop and reflect. So was it responsible to push forward without an algorithm that we can't prove it was working? And in this case, this was where we decided we couldn't progress. But instead of just abandoning the work, because clearly we work for an organisation called Pioneer, we want to be pioneering, we want to be innovative, but actually we realised that we couldn't carry on that way, but there was still some learning to have, and that's part of why I'm here today, to also share what we learned. So really what we wanted to do and what we started now doing is we've stopped that piece of work, but actually what we are doing is writing a technical paper. And also that means that we can reflect and learn from it as a team. So how can we improve in the future? But also then hopefully that others, people like yourselves on this call today and others who'll read this paper can learn. But what we did learn was that NLP is a really powerful tool. But we have to use it in context, and we have to know when to use tools. Like any tool, they have to have the right use. Absolutely, we have to collaborate with our clinicians, and my data scientist whispered in my ear before I gave the talk today, please make sure that we really put that out there, that those clinicians and that clinical input and validation is absolutely critical. We can't rely on AI alone. And furthermore, we do need some of that structured data to compare to. So otherwise, what we're doing is really making unvalidated assumptions. So we haven't given up on the project, and we are looking to do a sort of prospective trial where we can collate that data in a different way so we can really test that algorithm, but we did have to pause in respect of this. So finally, was it a failure? Probably. Yes, it was a failure because we didn't get to the end. But was it a learning experience? Absolutely, it was a learning experience. And so whilst we didn't end up where we expected to be with our sarcopenia algorithm and to be able to share that and write our paper, we did learn a lot of valuable lessons in terms of starting out on projects like this, especially when you're talking about AI and that real innovation piece, just to reflect and learn. So hopefully that's just an anecdote, lots more details and tech, but I'm out of time.